topic is the impact of this NAFLD to MASLD in Asia. And the second one is the cardiovascular risk of MASLD patient. As we know that cardiovascular events may be the leading cause of the mortality of the MASLD. And finally, Professor George will talk about the potential treatment of NASH. So I think this today's program will be very fruitful for all the audience. So we will start with the first speakers. So we will welcome Professor Wong to chair this session. Professor Wong, please.
Thank you, Professor Lin. It gives me great honor and pleasure to introduce the first speaker, Professor Huang Jifu. Professor Huang graduated from the Kaohsiung Medical University in 1989 and received his PhD at the same university. He is currently clinical professor of the Hepatology Division of the Kaohsiung Medical University Hospital and the chief of the Hepatitis Center. He is also serving as the Secretary General of the Taiwan Liver Research Foundation. He has contributed much to liver research. His main research interests include basic and clinical research in viral hepatitis, fatty liver disease, and liver metabolism. He has published numerous articles in peer-reviewed journals and conducted many clinical trials. This evening, he is going to tell us what the impact of the change in the name and definition of MASLD would be in Asia. Professor Huang, please.
Thank you. Thank you, Professor Wong. I've recorded the video, and after that, I'm pleased to answer any question. Thank you. Many thanks for your kind introduction, Professor Wong. Good evening, dear professors, dear colleagues, and dear friends of APASL. It's my great honor to have the talk in this terrific webinar. My talk today is entitled The Impact of NAFL to MASLD in Asian Patients. As we all know that NAFL is the most prevalent liver disorder and the metabolic disorder globally, with the prevalence reaching 25%. Asia Pacific region is an exact example in parallel to the rapid westernization after World War II. The review article summarized roughly the changing prevalence of NAFL among the major countries in Asia. Most of the countries faced the increasing trend of NAFL during the past decade, except India, Japan, and Singapore. An important essential issue is that compared to other races, Asians are more susceptible to the insults of metabolic disorders such as hypertension and diabetes. As shown on the lower panels, given the same level of BMI, more Asians easily developed hypertension and diabetes than other ethnicities. Therefore, the common lower BMI of Asians does not appear to provide overt protective effect against metabolic abnormalities. The community-based study was conducted by Professor Wong from Chinese University of Hong Kong. By using MR spectroscopy for steatosis detection, they demonstrated nicely that the prevalence of NAFL in Hong Kong increases with age. It was less than 30% in those aged less than 40 years, and more than 50% in those older than 60 years. The prevalence increases in men throughout life, but in women, the prevalence does not increase until the fifth decade, after which it rises steeply. It implies that we should pay more attention and effort to the elderly, particularly those menopause women in a clinical care setting. We had analyzed our community-based cohort study by recruiting near 2,500 adults recently. 16% of them had metabolic syndrome. The overall prevalence of NAFLD was 45%, ranging from 26% in those aged less than 30 years to 54% in those aged 50 and more. The right panel demonstrates that there is a parallel increase of prevalence according to BMI. Of note was that the prevalence among those normal BMI was 26%. Insulin resistance is the significant predictor in both obese and lean NAFLD patients in this study. The current definition of NAFLD is based on the exclusion of alcohol and other causes of liver steatosis. However, it's not reasonable, since the diagnosis criteria of a disease should be based on the positive criteria, but not by exclusion. Since its first description is distinct from alcoholic liver disease based on a cutoff of daily alcohol intake. However, a set limit of alcohol intake regarding the liver risk may not exist based on scientific evidence. Moreover, the amount of alcohol intake are often underestimated. The liver triglyceride content for 5% or more was not based on the strong evidence. Steatosis may be much diminished or even absent upon the fibrosis progression to cirrhosis, so-called cryptogenic cirrhosis. In addition, metabolic alterations have a higher impact than alcohol on the disease course of alcoholic liver disease. The metabolic derangements are not uncommon in other liver diseases, and they may worsen the disease course, as the story we observed in HCV infection. Therefore, the term of NAFLD should be revisited and should be renamed into a logical and feasible manner. Tracing back the history track, Dr. Ludwig coined the term NAFLD-NASH in 1880. It has not been challenged until 2002, and APASL STC indicated that the metabolic steatohepatitis should be considered, but no consensus was reached at that time. However, many experts in the conference have repeatedly proposed the metabolic issue should be taken into an essential consideration in the aspect of fatty liver disease. In 2020, a panel of international experts from 22 countries made a consensus statement and proposed a new definition for the diagnosis of MASLD that is both comprehensive and simple, and is independent of other liver diseases. The experts proposed that disease severity assessment and the stratification should extend beyond a simple dichotomous classification to steatohepatitis versus non-steatohepatitis. The criteria based on evidence of hepatic steatosis, in addition to one of the following three criteria, namely overweight or obesity, presence of type 2 diabetes, or evidence of metabolic dysregulation among those lean or normal weight patients. The metabolic risk for those lean or normal weight patients includes the 5 components of metabolic syndrome: HOMA-IR 2.5 or more, and plasma hsCRP higher than 2. Professor Wong delicately pointed out the impacts of the new definition on our understanding of clinical diagnosis. The new definition lifts the traditional 3 bands of exclusions, namely exclusion of excessive alcoholic use, exclusion of viral hepatitis and other liver diseases, and exclusion of secondary causes of fatty liver, such as methotrexate and tamoxifen use. The new definition requires the prerequisite of metabolic alterations prior to diagnosis, It therefore opens some windows in fatty liver issue. The impacts of the new definition on the current landscape of fatty liver disease could also be listed at least in 3 parts, including epidemiological studies, the interplay with other common liver diseases such as HBV and HCV infections. Of course, the impacts on the liver-related outcomes also occurs. How come the results when comparing the old and new nomenclatures? Professor Wong conducted the population study focused on the impacts of the definition of MASLD on the prevalence and the incidence of disease by using data from a well-characterized population screening cohort. The patients were diagnosed by using MR spectroscopy and transient elastography. The study demonstrated nicely the prevalence of MASLD and NAFLD was similar at 26%. The concordance was quite consistent in different age groups and genders. Figure A demonstrates that the prevalences were comparable between NAFLD and MASLD stratified by different BMI status. Figure B on the right side showed that the incidence of NAFLD and MASLD in subjects who had liver fat less than 5% at baseline and underwent the second examination at a median interval of 47 months. The incidence of MASLD was 2.8 per 100 person years, which was 25% lower than that of NAFLD. The difference was more marked among patients with BMI less than 23. The result may suggest that people without fatty liver at baseline had a lower metabolic burden and less likely to fulfill the metabolic criteria for MASLD even when liver fat increased. Another question is, what's the highest proportion of advanced fibrosis between the 3 groups of MASLD in a real-world setting? Recently, we had a chance to compare the difference of disease severity between 3 groups of current MASLD definition in a community-based cohort. Near 2,000 MASLD adults meet the steatosis criteria of both sonography and the fatty liver index more than 60 were recruited. They were classified into 3 groups accordingly. Table on the right shows that those who had advanced fibrosis, defined as FIB4 more than 3.25, had older age, lower BMI, total cholesterol, HOMA-IR, and platelet levels than those who without advanced fibrosis. They also had higher HCV infection and transaminase levels than their counterparts. Multivariate analysis demonstrate that Hep B, Hep C co-infection, HCV monoinfection, Group C patients, Hep B infection, and age were significant predictors of advanced fibrosis in this community-based cohort. The Group C patients had the significantly higher proportion of advanced fibrosis than other 2 groups, irrespective of the presence of viral hepatitis infections. Fibrosis is the key predictor for liver-related outcome in MASLD. Therefore, the results suggest that we should pay more attention in the lean MASLD patients carrying metabolic alterations based on risk stratification. When the bands of the exclusion criteria have been lifted with the new nomenclature, it provides a wide space for elucidating the interplay between MASLD and viral hepatitis infections such as HBV and HCV in our region, where both liver diseases are prevalent and endemic. Either HBV or HCV had its characteristic protein and inflammatory processes by which may affect the disease course of MASLD from steatosis to cirrhosis and liver-related events. One of the examples is the HCV proteins, which could lead to the development of viral steatosis and metabolic steatosis during chronic infectious processes. The steatosis and its related insulin resistance or metabolic syndrome could exacerbate the existing steatosis feature of MASLD patients. On the other side, the presence of MASLD modified by genetic predispositions, epigenetic changes, and Western lifestyles could also contribute to the disease alterations in patients with chronic HBV or HCV infections. The new definition also opened a wide scope of view addressing the impact of fatty liver on clinical outcome of HBV. Our recent study aimed to evaluate the effect of fatty liver on cirrhosis, HCC, and surface antigen seroclearance instance in chronic Hep B patients. In this retrospective cohort study of more than 6,700 Asian Hep B patients, we used the propensity score matching to balance the fatty liver Hep B and the non-fatty liver Hep B groups. Compared to non-fatty liver Hep B patients, fatty liver Hep B patients had lower 10-year cumulative incidence of cirrhosis and HCC, whereas they had a higher surface antigen seroclearance rate. It suggests that the interplay between fatty liver and Hep B existed in terms of disease course and outcome. Further analysis with Cox proportional hazard model indicated that fatty liver remains to be significantly associated with the lower risk of cirrhosis and HCC, and it carries a higher chance of surface antigen clearance in antiviral treated patients, but not in untreated patients. While fatty liver-related HCC is known to occur in the absence of cirrhosis, our understanding of fatty liver-related HCC in this setting is limited. Therefore, our recent study aimed to characterize MASLD-related HCC and the impacts of cirrhosis and the screening on survival. This multi-nation, multi-center study conducted in the United States and Asia. Cirrhosis was present in 62% of patients, but less than half of these patients received imaging surveillance within 1 year of HCC diagnosis. The major results were cirrhosis was not associated with overall survival. Second, history of abdominal imaging with a year of HCC diagnosis was associated with improved prognosis, whereas symptoms at HCC diagnosis were associated with poor outcome. Third, the HCC surveillance rate in patients with MASLD-related HCC was disappointingly low. The result implied that additional efforts are needed to improve adherence to HCC surveillance in MASLD cirrhosis patients. The algorithm subsequent to the new definition may be proposed in this slide. Advanced fibrosis should be assessed firstly by either panel-based or imaging-based non-invasive methods. Special referral for liver biopsy or cirrhosis assessment is considered among those with intermediate or high risk. The therapeutic options include lifestyle modifications, body weight reduction, management of metabolic abnormalities, and potential clinical trials. Of course, surveillance of liver-related events and HCC is mandatory for those patients with advanced fibrosis. The new definition of MASLD may overcome the long-term caveats of novel definition. However, there is still room for improvement of the new positive definition into an ideal one. It may include the specificity, simplicity, and validation for diagnosis, outcome prediction, and potential treatment approach. Moreover, there are some potential uncertainties of MASLD, such as precise measurement of adiposity, the interaction with other concomitant liver diseases, and the heterogeneity of metabolic syndrome. In addition, a steatosis-centered new histopathological evaluation score may be needed for clinical management. In conclusion of my talk, dear Chairperson and dear colleagues, we all agree that fatty liver disease is the most prevalent liver disease and the most prevalent metabolic disorder in our region. The new nomenclature definitely changed the landscape of fatty liver disease. We do need to validate the new definition in terms of disease course, outcome, and the interplay with other common liver diseases. Based on the view of patient care, risk stratification and the different phenotype elucidations are challenging tasks, but the efforts should be done for the purpose of precision management. Thank you very much for your attention.
Thank you, Professor Huang, for your excellent talk. And I can see that there are already some questions in the chat box. So we encourage you to ask more questions, and we will leave the questions and answers till the end of this session. And now may I pass the time to Professor Yu to introduce the second speaker.
Thank you, Vincent. So after the comprehensive review of the NAFLD in Asian population by Professor Huang, we are going to talking about the so-called extrahepatic manifestation in the patient with MASLD or MASLD. So I think everybody knows very well the MASLD is not only a liver disease but also a systemic disease because they are based on the phenomenon of insulin resistance. So it's very important to know about the extrahepatic manifestation in this patient population. So today we are very happy to have Professor Sun-Ah Kim to deliver the topic, the cardiovascular risk of MASLD patients. It's my great honor to introduce Professor Kim. He's a professor in the Department of Internal Medicine, Yonsei University College of Medicine in Seoul, Republic of Korea. He is a member of Korea Association for the Study of the Liver and Korea Liver Cancer Study Group. He has more than 250 SCI original peer-reviewed publications as primary or corresponding author. He is as an editor-in-chief of Clinical Molecular Hepatology, an associate editor of Gut and Liver, an academic editor of PLOS ONE, and editorial board member of Clinical and Translational Hepatology. He is an invited referee for more than 15 SCI journals, including Gastroenterology, Hepatology, Journal of Hepatology, and etc. His major research interests include viral hepatitis, viral and liver fibrosis, and liver cancer. So ladies and gentlemen, please join me to welcome Professor Kim. Professor Kim, please.
Thank you very much for your nice introduction. I also have a pre-recorded video, so please. Thank you for your kind introduction. Also, thanks to the organizing committee for inviting me here to this important APASL webinar. My talk today is on the cardiovascular risk of a MASLD patient. First of all, I'd like to inform you that Clinical and Molecular Hepatology, the official journal of the Korean Association for the Study of the Liver, has recently achieved an impact factor of 8.3. I'm now working as the editor-in-chief of this journal, so if you have any interesting research results, please do not forget to submit them to CMH. The figure on the right is the cover page of the most recent issue, showing the main result of an accepted paper on the association between fatty liver and the risk of dementia. These are the contents of my presentation today. let's start with a short introduction. Non-alcoholic fatty liver disease is the most common cause of chronic liver disease in Western countries and is predicted to become the most frequent indication for liver transplantation by 2030. The clinical burden of MASLD is not only liver-related morbidity and mortality. There is also growing evidence that MASLD is a multi-system disease that affects extrahepatic organs and regulatory pathways. Type 2 diabetes, cardiovascular or cardiac disease, and chronic kidney disease are the examples. Let's first look at the risk of CVD in MASLD. Patients with MASLD typically have features of the metabolic syndrome and other emerging CVD risk factors. In a recent meta-analysis of 27 cross-sectional studies, a strong association between MASLD and several markers of subclinical atherosclerosis, such as increased carotid intima media thickness, increased coronary artery calcification, impaired flow-mediated vasodilation, and arterial stiffness was reported. These associations were independent of classical CVD risk factors and metabolic syndrome features across a range of patient population. Recently, another meta-analysis was published in CMH. I'm not going to show all of the data. Looking at the study highlight, in a pooled analysis of 30 studies involving around 8,000 patients with MASLD, 35% had carotid atherosclerosis with an odds ratio of 3.2. A pooled analysis, 25,000 patients with MASLD found the prevalence of stroke to be 5% with an odds ratio of 1.88 compared to non-MASLD. Based on these findings, the author suggests the need for routine assessment of carotid atherosclerosis in MASLD patients. There is debate over the new definition of fatty liver. However, I believe that no one doubts that MASLD or MASLD increases the risk of CVD. In 2020, a panel of international experts proposed a new nomenclature, MASLD, to replace NAFLD. The MASLD inclusion criteria are based on the degree of metabolic abnormalities and do not exclude other etiologies. The NAFLD to MASLD change would accommodate identification of metabolically complicated fatty liver superimposed on chronic liver disease or alcoholism, and would exclude fatty liver unrelated to metabolic dysfunction. However, the clinical impact of this change is under debate. I think that patients with metabolic risks have been followed and received appropriate medical interventions by hepatologists, endocrinologists, cardiologists, and or nephrologists, even without the new concept of MASLD. Thus, MASLD might be recategorizing or regrouping a population without any change in disease status. Use of the term MASLD might have highlighted the clinical importance of metabolic dysfunction, but whether it improves the disease status in clinical practice needs to be assessed. Because it focuses on metabolic dysfunction, it is plausible that MASLD captures metabolically complicated fatty liver not included in the NAFLD definition. At the same time, it may render the affected group more homogeneous by omitting a small proportion of individuals with metabolically uncomplicated fatty liver. In our recent study based on a nationwide health screening database, we evaluated the prevalence of fatty liver disease and the associated CVD risk using MASLD and MASLD. In this study, 9 million participants were followed for a median of 10.1 years. As you can see in the middle, the prevalence of MASLD and MASLD was 28% and 37.3% respectively. The difference in prevalence might be due to the inclusion of patients with more than 2 etiologies in the MASLD definition. At right, you can see the risk of CVD based on the definition of MASLD only, MASLD only, or both type of fatty liver disease. MASLD and MASLD were each associated with a significantly higher risk for CVD event. When the study population was divided into 4 groups, as at lower left, the MASLD only and overlapping groups showed higher risk of CVD than neither fatty liver disease or MASLD only group. Using the neither fatty liver disease group as the reference, the multivariable adjusted hazard ratio for CVD event was 1.41 in the MASLD group and 1.52 in the MASLD group. Using the neither fatty liver disease group as the reference, the multivariable adjusted hazard ratio for CVD event was 1.09 in the MASLD only group, 1.43 in the MASLD only group, and 1.56 in the both fatty liver disease group. These indicate that the change from MASLD to MASLD may identify a greater number of individuals with metabolically complicated fatty liver and an increased risk of CVD. But we should keep in mind that MASLD only, that is non-metabolic risk MASLD, which typically has favorable long-term outcomes, has a significantly higher risk of CVD compared to the control, although the risk might be lower than that of MASLD. Non-metabolic risk MASLD at one point in time does not necessarily mean that it will persist throughout the patient's life, because aging increases the risk of metabolic features such as diabetes or dyslipidemia, resulting in a change in disease subgroup to MASLD. Our recent cross-sectional study of asymptomatic subjects undergoing health checkups yielded similar findings. Around 2,100 subjects undergoing coronary CT angiography were evaluated. The prevalence of MASLD was higher than that of MASLD. MASLD and MASLD were significantly associated with the presence of coronary artery disease, which was maintained after adjusting for confounders. The odds ratio of MASLD was slightly higher than that of MASLD, 1.57 versus 1.38. Compared to subjects with MASLD only, those with MASLD showed a significantly increased risk of coronary artery disease. Adjusted odds ratio was 2.89. Compared to subjects without fatty liver, those with MASLD only showed a statistically similar risk of coronary artery disease after appropriate adjustment. In contrast to our previous study, there was no difference in the risk of coronary artery disease between neither fatty liver disease and MASLD only group. When high ASCVD risk was used as the endpoint instead of coronary artery disease, the main findings were unchanged. Accordingly, MASLD might be better or at least similar in terms of identifying patients at higher risk of CVD than NAFLD. Similar to NAFLD, it is plausible that the CVD risk varies among MASLD subgroups. The three major subgroups are shown here. In our previous study, we showed that the CVD risk varies according to fibrotic burden and muscle mass in non-alcoholic fatty liver disease. The presence of NAFLD and sarcopenia showed strong positive relationships with quartile stratified ASCVD risk. You can see the stepwise increase in ASCVD risk. Relative risk for high probability of ASCVD was highest in subjects with double positive risk factors, that is NAFLD and sarcopenia. Similarly, when patient with NAFLD was selected, as shown here on the right, the relative risk for high probability of ASCVD was highest in subject with double positive risk factor of significant liver fibrosis and sarcopenia. Likely because of the significant overlap between NAFLD and MASLD, we expected similar findings. Our recent study showed that the fibrotic burden determines the CVD risk among patients with MASLD. Similar to previous slide, the proportion of subjects with a high probability of ASCVD risk was high in the group with significant fibrosis and MASLD. Interestingly, the risk was statistically similar between non-MASLD and MASLD without fibrosis. This indicates that, similar to NAFLD, MASLD has a subgroup with favorable outcomes, although MASLD tried to focus to select high-risk population. The number of MASLD risk factors such as overweight obesity, central obesity, hypertension, hyper-TG, hypo-HDL, prediabetes, and high HOMA-IR was significantly greater in subjects with both MASLD and significant liver fibrosis than in those without MASLD or with MASLD but without significant fibrosis. This analysis was conducted after matching groups based on propensity score. This table shows the association between a high probability of ASCVD risk and the existence of MASLD significant liver fibrosis after multiple adjustment. Subjects with both MASLD and significant liver fibrosis had a significant 4-fold higher risk than those without MASLD. In addition, there is a significant association between muscle mass and CVD risk among MASLD patients. Among MASLD patients, those with sarcopenia had poorer demographic and laboratory characteristics. In addition, sarcopenic patients had greater degree of fatty liver, fibrosis, and CVD risk than non-sarcopenic patients. The ASCVD risk score, stratified by quartile, significantly increased from subject with a MASLD to non-sarcopenic subject with MASLD and sarcopenic subject with MASLD. The proportion of patients with high-risk ASCVD is almost 60%, and the relative risk is around 8-fold if the patient had MASLD with sarcopenia. The adjusted relative risk in patients with MASLD and sarcopenia was increased 4-fold compared to those without MASLD and 3-fold when compared to those with MASLD but without sarcopenia. So far, I have explained the CVD risk in patients with MASLD. In addition to a direct association between CVD risk and MASLD, muscle mass, and liver fibrosis, which are linked to CVD risk, appear to independently influence each other. There are three main subtypes of MASLD. Before ending my presentation, I'd like to share our data regarding the CVD risk in these subtypes of MASLD. This study investigated CVD risk according to MASLD subtype using a nationwide health screening database. The cumulative incidence of a CVD event was highest in the DM MASLD group, followed in descending order by the lean MASLD and obese or overweight MASLD and non-MASLD groups. Despite the lack of information on muscle mass, the favorable outcomes in patients with obese or overweight MASLD suggest that they have greater muscle mass than patients with other subtypes, such as lean or DM MASLD. To investigate the association of overlapping MASLD components, we categorized participants into 7 mutually exclusive groups according to the combined presence of diabetes, obese overweight, and metabolic abnormality. Lean MASLD was associated with a higher CVD risk than obese or overweight MASLD with or without metabolic abnormality. Likewise, among patients with DM MASLD, lean participants had a higher risk than those who were obese or overweight. The presence of advanced liver fibrosis was associated with a higher CVD risk irrespective of MASLD subtype, with the greatest excess risk for the lean MASLD subtype. Compared to overweight or obese MASLD without advanced liver fibrosis, obese or overweight MASLD with advanced liver fibrosis, and lean MASLD with advanced liver fibrosis had higher CVD risk, whereas lean MASLD without advanced liver fibrosis did not. With or without advanced liver fibrosis, DM MASLD has the highest CVD risk of the MASLD subtype. These findings indicate that long-term CVD outcomes differ according to MASLD subtype. In conclusion, before changing the nomenclature from NAFLD to MASLD, the advantages and disadvantages for the scientific community, care providers, and patients should be considered. However, I believe most importantly, any change in name must have advantages for patients that outweigh the potential disadvantages. So, ladies and gentlemen, I want to conclude my presentation. Similar to NAFLD, MASLD is associated with an increased risk of CVD. The CVD risk varies according to MASLD subtypes. Assessment of fibrotic burden and muscle mass is required for CVD risk stratifications. Further studies are required to identify patients at high risk of a CVD event who require more intensive medical intervention. Thank you very much for your attention. Here you can see our faculty members at Yonsei University Hospital.
Thank you very much, Professor Kim, for the comprehensive review and sharing the most updated data in the relationship between the cardiovascular risk and the MASLD. So right now, I would like to hand over the microphone to the next moderator, Professor Junko Tanaka. Professor Tanaka, please.
Thank you, Professor Yin. Good evening, everyone. So I'm Junko Tanaka from Pearson University. Today, we are welcome Professor Jacob George, so very famous, as you know. So I'm very honored to introduce him. So today he will present on the ongoing potential drug treatment for NASH, which is everyone, hepatologists, specialists, want to know the status of this issue. I'd like to introduce him briefly. So Professor Jacob George is a professor of the Westminster Institute for Medical Research, University of Sydney, and also head of the Department of Gastroenterology and Hepatology at the Westmead Hospital. And his specialty, of course, basic and clinical research on MASLD, of course, NASH, hepatitis C, liver cancer, and hepatic fibrosis. He is an associate editor for the Journal of Hepatology and is many editorial board such as Hepatology, Hepatology Communications, Liver International, and World Journal of Gastroenterology. And also he is a current chair of the Liver Faculty of Gastroenterology of the Society of Australia. So please listen to his talk tonight. Let's begin to his talk. George, please.
Okay. So first of all, thank you very much to Professor Tanaka, Professor Yu, and Professor Lin from APASL for inviting me to this thematic webinar on the cardiovascular risk and potential pharmacological treatment. And what I thought I would do is be a little bit provocative and a little bit different from the usual talks about MASLD and drug development, because I think you've heard it in every conference that you go to. And I thought I would actually focus on potential drug treatment in relation to MASLD, and particularly focusing on cardiovascular risk. So in terms of what I'm going to talk about, I think the next slide I'm going to have, everyone has seen it from the previous two speakers. Then I'll just talk a little bit about MASLD and cardiovascular mechanisms. And then I want to talk about, some of the concepts on managing the MASLD patient. And then I think, rather than this aspirational goal of looking at what drugs will be available and there's millions of clinical trials and pluses and minuses, I'd rather actually say what pharmacological approaches can we use for the MASLD patient today in 2022. So just one slide on the MASLD definition, and I think the previous speakers have also spoken about it. And as you know, APASL was the first pan-national society to adopt the terminology. And when we actually developed the terminology, our biggest thought was it should be a diagnostic criteria. In other words, you're a clinician sitting in front of a patient. You need to be able to remember the definition off the top of your head. So it's got to be simple, and it's got to tell you what the disease is. In other words, a positive criteria. And as Professor Kim has adequately shown, and also Professor Huang, you need steatosis, and we have one of these three categories: overweight or obese, type 2 diabetes, and then you have MASLD. Or if you're normal weight, you need a couple of metabolic risk abnormalities. So immediately you can see it is telling us what is this disease. And every doctor in every clinic, from a small village to a tertiary hospital, doesn't need a lot of brain power. It's at your fingertips. And it's a set of positive criteria in all settings. You'd be interested to know that the Lancet Commission last year actually suggested that we need to change the term from NAFLD to MASLD. Why? Because it allows for pathological specification, and it accounts for the synergy, as Professor Huang mentioned, the synergy and looking at furthering hepatology by understanding dual diseases when they occur. Now, just think about hepatitis C, for example. In hepatitis C, We're very happy to diagnose someone with hepatitis C based on a blood test. It doesn't stop us checking them for hepatitis B. And whether they are tested for hepatitis B or not, they have hepatitis C. MASLD is exactly the same. If you meet the definition, just like Hep C, you've got MASLD. And as a group, you're very welcome to check for the other diseases. And in some countries, it might be viral hepatitis. In other countries, it might be statin use or methotrexate. It just depends on the clinical situation. The MASLD definition doesn't prevent you from thinking about the patient. So we've heard from the previous two speakers about MASLD and cardiovascular risk, and particularly with Professor Kim showing you all the different criteria, the three stratification. Now, isn't that a fantastic outcome of just having a definition? All of these studies that Professor Kim and others have done showing differential impacts from that stratification. After 40 years of MASLD, we just haven't had that sort of a stratification, that clear description of different pathological developments. So coming back to the concept of MASLD and cardiovascular risk, why does it occur? And I think the fundamental etiological predisposition to MASLD and to cardiovascular risk is meta-inflammation related to excess adiposity. So when you get excess adiposity, your homeostatic immune signals decrease and your pro-inflammatory signals increase. And it occurs simultaneously in all parts of the body. In the brain, you get hypothalamic inflammation, adipose tissue macrophage infiltration, inflammation, adipose insulin resistance and cytokine release. In the liver, we get the same inflammation, we get MASLD. In the muscle, we get lipid deposition, macrophage infiltration, and muscle insulin resistance. In the vascular tree, you actually get lipid deposition and atherosclerosis. And when you get pancreatic lipotoxicity, you get beta cell failure and type 2 diabetes development. So it is actually the one disease, all starting with inflammation, with individual variation based on geography and food and genetics and all of those other factors, but it gives you simultaneous meta-inflammation. And different people might have different organs affected in slightly different manners. So some people might have very much a cardiovascular phenotype, others might have a diabetes phenotype, and that's just, things that we will learn about in future, but it's simply put, it's meta-inflammation. And to just highlight this particular aspect, if you think of MASLD and try and link it to cardiovascular disease, in MASLD you get inflammation. In MASLD you get fat deposition, so it's like adipose tissue, but it's happening in the liver. You get RAS activation. You get oxidative stress. There is peripheral insulin resistance, but when you get liver fat, you get hepatic insulin resistance. On the flip side, in the blood vessel, exactly the same etiological factors are happening. So you're getting vascular inflammation, you get vascular lipid deposition from fatty streaks from early childhood, you get vascular remodeling because of RAS activation, you get endothelial injury, and you also get hypercoagulability, and hey presto, you get cardiovascular disease. Now, if you look at the last 15 years, there's been a lot of data saying, is liver fat an independent predictor of cardiovascular risk? And is it that the diabetes gives you liver fat, or the hypertension comes first, or the cholesterol comes first? And I think that argument and the variation in the literature is actually quite a stupid debate. You think about it quite deeply. The initial insult in this metabolic disease is adiposity. And obviously, for us as hepatologists, you get liver fat. Now, once you get these drivers, then the disease progresses to all of these other causes. And obviously, if you get a proximal risk factor, that's what's going to show up in your MACE events. If liver fat doesn't show up when you add it to your cardiovascular risk score, it doesn't mean anything. All we're saying is, liver fat contributes as a very early driver, which then proceeds to the proximal risk and then gives you your cardiovascular MACE events. Now, what about drugs for MASLD? And this is a recent paper that Vlad Rathiou wrote in Journal of Hepatology. And then he was talking about the physiology and the targets. And what's clearly evident is the targets are even more complex. In Hep C, it was easy, just a virus. Hit the virus, you're gone. Hepatitis B is much the same. But look at the number of targets that we've got for MASLD. And the problem with all these targets is, on the one side, they sound exciting for a clinical trial, but on the other side, you realize the number of pathways that are involved. And the human body hasn't evolved for 3 million years without a lot of redundancy. And when you get redundancy, you can knock off, PPAR alpha, and then some other pathway will overcome it, as long as you continue to eat the wrong foods and not exercise as well. And so for the challenge for any of these drugs are going to be the redundant pathways that are going to impact the final outcome. But of all of these drugs, I think the GLP-1 agonists and the GIP dual agonists are the most promising, simply because they target the core pathophysiology, which is the adiposity. And all of these others, yes, they might show some benefit, but they do have problems. But we need to wait to see how the trials evolve. Now, this is the great hope for drugs in MASLD, okay? But I'd like to highlight for you some of the problems we've created for ourselves with this paradigm for drug development that we've developed. So classically, what we're now doing is selecting the patient. I prefer to call, instead of NASH, I think it's more appropriately called metabolic steatohepatitis. So we select patients with metabolic steatohepatitis in F2, F3, and then we are hoping to get conditional approval based on mesh resolution or fibrosis regression. And then eventually you get full approval if you decrease the progression to cirrhosis, and ultimately you want to reduce liver-related outcomes. So that's a great goal. That's what we want to achieve. And then the hope is that in the next phase, once you've shown these in the initial trials, then maybe we can recruit patients, and all we need to do is show histological improvement. And then because the first study has done it, we don't have to wait till cirrhosis develops or doesn't develop. We can say histological improvement is a surrogate for lowering of cirrhosis. And then eventually, for a cirrhotic patient, you'd actually start thinking about reduced outcomes. And finally, where we'd get to is, without a biopsy, we'd get a NIT-based treatment response, a non-invasive marker, and then you could get, it reflects liver histology, reflects cirrhosis development, reflects outcome. But what are the problems with this current paradigm that we've got? As I've shown you, this is all about metabolic risk. And unfortunately, for our field, there are competing risks from other mortalities, so elegantly pointed out by Professor Kim and Professor Wang. So competing risks, roughly twofold of cardiovascular disease, and roughly twofold for cancer risk. And remember, it's more important than just saying it's an odds ratio. We need to think about the number of people that are going to be dying in any given population from cardiovascular risk or cancer risk, because they're so much more common than liver-related endpoints. So your trials are going to be impacted by a competing morbidity and mortality, which is going to dilute the ability to show cirrhosis progression, reduce cirrhosis progression or outcomes. The next problem is that we've gone and cornered ourselves with a liver biopsy where you see 2 or 3 balloon cells in a biopsy. For international pathologists have only got a 50% concordance in diagnosing steatohepatitis by ballooning. And there's biopsy variability. And then the problem is that to diagnose steatohepatitis, you need a biopsy. There's no molecular test that will tell you, and I predict it's not going to tell you with robust data, even in the future, about metabolic steatohepatitis within it. The reason I say that is that steatohepatitis is a transient lesion. I can have an HbA1c today of 10, and you can see me, and I'll have steatohepatitis. 3 weeks later, I can have an HbA1c of 7 with good diabetes management, and there won't be any steatohepatitis. So it's a transient lesion, that's a problem. And the last problem that we've cornered ourselves into is with fibrosis reversal or reduction as an endpoint. Now, we've got data from Hep C, the IHIT studies done in Japan in the interferon era. We've got the Hep B data. And we know that fibrosis progression in MASLD goes at about 1 fibrosis stage for 7 years. And with the Hep C, when you completely get rid of the insult, it reverses at about 0.2 stages per year. In other words, to reverse 1 stage, you need 5 years. And guess how we do all our trials? We're doing biopsies in 1 year. And 1 year is not going to be sufficient based on all the data we've got where we've killed the virus with Hep B or C. Remember, our MASLD patients are continuing to have cardiovascular risk and eating unhealthy and continuing to have their ongoing insults. So these are some of the problems that we've created for ourselves with the current paradigm that's histology-based and trying to find liver-related outcomes. And just to show you my problem that I was talking about with competing risks. This is a large study that we did, 500 patients with either F3 or F4 fibrosis. Remember, the big phase 3 studies in MASLD only have about 2,000 patients. But this is about a quarter of the study. So if you look at hard endpoints, and in this particular study, they were all transplant centers that recruited patients. So there's a huge amount of referral bias. And even in those 450 patients, after a median follow-up of 5 years, there were just 37 deaths. That's a very small number. In the F3, after 5 years, there were just 4 deaths, and 50% of the deaths were cardiovascular disease, and there were no liver transplants. And then you think about our trials, which are 52 or 72 weeks. Then when you look at the A5 and A6, Charles-Pugh A, you can see that the A6 would never get into a clinical trial because they usually have a low albumin. They begin to get more liver-related events. But at the end of the day, after 500, it's a very, very small number. And all the ones we're putting into MASLD clinical trials, they're not going to get the liver transplant because they'd be precluded if they were that far advanced. But the other problem that we've now got, again, highlighting a bit about competing risks. This is from the Global Burden of Disease Study. 8.5 million adults with obesity. What do they die from? 2/3 of the cases actually die from cardiovascular disease. Cancer is the one in green, chronic kidney disease, diabetes. So among 68.5 million patients, you can't even see a blip from liver. So we've got a problem with these competing risks that we're dealing with because it's the one systemic disease that we have. And yes, we all see patients with fatty liver that's progressing and progressing. But on the bulk in the population, this is what's actually killing our patients. So what can the data that we have currently tell us the clinical data. And this is a very interesting study from 2018, looking at patients with type 2 diabetes. So 271,000 type 2 diabetics compared to 1 million controls from Sweden. And they were age, sex, and county matched. Again, a follow-up, 5 years. And they looked at their entry criteria. Is the HbA1c in these diabetics above or below 7? LDL over or under 5? Smoking, yes or no? Albuminuria? And what was their blood pressure? And they looked at what actually killed them, the MACE events. And if you look at it on the right here, these are controls. In other words, they don't have diabetes, and all of these factors are within the lower range. So irrespective of your age, whether you're under 55 or you're over 80, that's set as a reference range. And then when you look at people who've got all 5 variables, all of these, in other words, no risk factors, your hazards ratio for death is only 1.06, minimal increase. Whereas as you go from 1, 2, 3, 4, and 5, your risk factors increase, and they increase with increasing age. So what that's telling you is we're not just about treating the liver. The patient in front of you wants to live longer. He doesn't care whether his liver lives that long or not. He just wants his heart to go for longer. And so the thing that we need to do for our MASLD patients today is we need to be able to control the risk factors. So how do we actually control the risk factors? And so this is my approach to the management and metabolic assessment of a MASLD patient today in 2022, while we're waiting for all the clinical trials. Because many of our 2/3 of our patients are going to die from heart disease, many of them from cancer and diabetes. And we know that smoking impacts liver. We need to tell them about smoking. We need to say that there's Mendelian randomization studies now that says that no alcohol consumption is safe. You need to reduce your alcohol consumption. Diet and exercise is a completely separate talk, and I don't want to actually talk too much about it just yet, because it's a separate talk. Then we need to look at that blood pressure, dyslipidemia, and type 2 diabetes. And we're hepatologists. We don't want to actually start managing, blood pressure and dyslipidemia. But I think the key thing that you can take from that Swedish study, and there are many other studies to that, is the cardiovascular guys have told us what targets we should be aiming for. And a lot of GPs don't actually know it. Cardiologists might know it. So we need to know that in any patient that we see with MASLD, we want their blood pressure to be less than 140. 150 is not acceptable. 160 is not acceptable. And if you can get it down to 130 in early disease, you need to be telling them, go to your primary care physician, get your blood pressure under control. Your LDL cholesterol must be less than 2.6. And you need to be able to tell your patient that. Very simple numbers, 140 and 2.6. And obviously the risk, the LDL comes down even lower, to 1.4, if you've got established cardiac disease. If you're a diabetic, you can easily do, there are lots of risk calculators out there, but your LDL cholesterol needs to be less than 2. Again, your blood pressure should be less than 140. And your type 2 diabetes, if you've got type 2 diabetes with albuminuria, you need to have your blood pressure less than 130 on 80. And I have all of these numbers. I don't necessarily treat my patients for these, but I know these numbers, I check them, and I say, this is what is recommended. It should be less than 1.8 or 2. Your blood pressure is too high. Go and see your primary care physician. That's going to prevent their death, as while we're worrying about their MASLD. So what about type 2 diabetes treatment? And I just want to highlight that if you've got a patient with diabetes, all recommendations across the world today focus on metformin as the first line. And then these are not in any particular order. SGLT2 inhibitors, GLP-1 receptor agonists and DPP-4 inhibitors. So this is the step therapy, metformin first, and type 2 diabetes, any of these drugs first. And you can see GLP-1 receptor agonists have a cardiovascular benefit. SGLT2 are great for heart failure, and they also have renal protective effects. We need to just know about these things. And I'm now comfortable with prescribing metformin for a patient, and I'm quite comfortable now prescribing GLP-1 receptor agonists in any patient I've got with diabetes. My obese patients are buying it over the counter, and I'm actually prescribing it to them if they want it. So what do we have in terms of the data? There's lots of clinical trials out there for MASLD, and this is one of the most promising. This is the semaglutide trial, and you can see it met the primary endpoint of mesh resolution, but not of fibrosis, the fibrosis endpoint. Is that expected? Of course it is. You know, when normal livers take 5 years, here we are expecting things to happen in just 72 weeks or 50 weeks. But the big important aspect is the GLP-1 agonists reduce your HbA1c, it reduces your lipids, and then when you look at cardiovascular outcomes, this is the SUSTAIN 6 cardiovascular outcome trial of placebo versus semaglutide. And when you look at the composite primary MACE event outcome, this is reduced. So your patients are going to live longer if they actually are on semaglutide, and if they're diabetic, they are going to actually live longer because that's what they care about. It's not just their liver, they care about their body. And this is the Pioneer 6 study, exactly the same, showing you reduced cardiovascular events with the GLP-1 agonists, and the same data is there for the SGLT2 inhibitors. SGLT2 inhibitors, everyone knows now, shouldn't have been a diabetes drug. It's actually a heart failure drug. And there is one study out there, they're making so much money from the cardiovascular protection, they're not really developing it too much for fatty liver disease, but it does reduce liver fat. So just to summarize, what should we do for MASLD treatment today? Yes, we need to focus on healthy diet, physical activity, weight loss. I have no problems prescribing GLP-1 agonists for my diabetic patients. And also if they've got obesity, it's not approved in Australia for obesity, but if the patient's willing to pay, I'm happy to give it. SGLT2 inhibitors have benefits in cardiovascular risk and does reduce liver fat. We don't tend to use pioglitazone because of the weight gain issue. And then, yes, there are drugs that have got potential benefit, including the ACE inhibitors, the FXR agonists. Vitamin E has been shown, but may have some benefit with cardiovascular risk. And then obviously statins are important for cardiovascular risk. So I think all of this disease is the one disease, and we really need to become metabolic physicians. Yes, we'll treat our liver, but there's lots we can do now. So just to complete it, the definition is very clear, and it's a positive definition for 2022. As I showed you, it has shared mechanisms. And in terms of managing the patient, just be very wary about competing risks and the importance of treating the whole patient. And we do have drugs that will alter patient outcomes today. So thank you very much.
Okay, thank you very much for the Professor George Jacob. So it was a privilege, a consideration, and from the many clinical trials. So the point of to reducing the risk. So your great talk about the treatment for the MASLD and cardiovascular diseases. So we have to move to the discussion section. So the first moderator is Professor Vincent Wong. So you have some questions to the impact. The first Professor Hyun. So let me.
Yes.
So
Yeah.
maybe we can also have a group discussion. So earlier
Yeah.
on, a colleague from the audience
Yeah.
typed a question saying that, yes, we can see the many benefits of the new term and definition of MASLD, but are we ready to make the change now? Maybe I will ask Professor Huang first, and I'm sure Professor George will supplement.
Yeah, it's a very important question. Yeah, particularly new nomenclature was proposed in 2 years ago. But I thanks a lot for the Professor George for who has delicately logically explained the rationale and reasons to changing the new nomenclature. And I think it's a excellent change because based on the patient's unmet needs, we need to focus on the disorder into a metabolic intent because it's a metabolic liver disorder, not just only steatosis. So we need to care the patients in terms of the liver and the extrahepatic manifestation, such as the Professor Kim just mentioned in his lecture that MASLD with the new MASLD nomenclature has a higher chance to identify higher risk for cardiovascular risk because which cardiovascular risk is the major causes of the old MASLD patients. Yeah, thank you.
Thank you, Professor Huang. Professor George?
Yeah, look, I support all of those comments, but for me, the simple conceptual issue is in 2022, how can we say we don't know what this disease is? It's whatever you get when you exclude everything else. And then even then, if you're a GP sitting in rural Australia or rural Hong Kong, have you excluded celiac disease? You know, you can't diagnose MASLD if you've got celiac disease. You can't diagnose MASLD if you've got, you know, you're on methotrexate. You can't diagnose MASLD if you're diabetic or obese, but you happen to be on a statin or some other drug that gives you steatosis. It just doesn't make sense. You don't actually use it. And in practice, what people do is they just exclude B, C, and alcohol. But it's not the definition that is actually written. Whereas this tells you, whatever else you have, this is what you have. You've got Hep C. Yes, you could have Hep B too. There's plenty of dual etiology disease. But we don't say that a patient has Hep C only if they've got B, D, E, F, whatever excluded. We say you've tested positive for Hep C, you got Hep C. As simple as that to me.
Yes, I agree with you. Now, let's move the question one step further. Now, of course, it is important to recognize that different liver diseases can coexist, and we should respect that the fatty liver disease would contribute to the natural history for patients with chronic viral hepatitis, for example. However, in the future, when we want to study the natural history or treatment of fatty liver disease, do you think we should allow inclusion of patients with chronic viral hepatitis, for example, knowing that the natural history is probably somewhat different in this group of patients?
Yes, and there's a very good precedent for that. So if you look at the first Hep C trials, you could only have Hep C, you had to not have Hep B, you couldn't have X, alcohol, this, that, and the other, or you couldn't have HIV. Once you prove that it's pure Hep C, which would be uni-MASLD, you know, just MASLD, once you prove it, then if you've got a patient with Hep B and MASLD, you can do trials in that, like we did for Hep C with HIV, or Hep C plus Hep B. So yes, you have to do it in as narrow a population as possible first, with proof of concept. And then after that, you can do it in all the other groups if you need to.
I'll ask one more question, and then I'll pass the time to the second moderator, because there is a typed question regarding the second talk. Now, this would be a very sensitive question. So Professor George and I knew it. So I think around 1 month ago, the ASLD and ESO conveyed a meeting talking about the nomenclature. So some of us in this panel are also involved in this exercise. Now, during the Chicago meeting, the patient groups strongly advocated that we shouldn't even use the term fatty liver disease. And there's a chance that they are pushing towards the nomenclature towards steatotic liver disease. Now, when that happens after the end of the Delphi process, if this is really what the people want, how would APASL respond?
Look, I don't think anyone's going to listen to that particular process, because the key is, if it's fatty, if I said you are fatty or someone else is fatty, looking at your shape, that can be stigmatizing. If you separate the fatty from the liver, then there's a problem. But we're actually saying it's a fatty liver. It doesn't say anything about the rest of you, okay? So I think it's very different from calling a person who has excess weight a fatty. And if you look at the world, there is a fatty, what is it called? Fatty liver, no, not fatty liver. There's a foundation called Fatty Liver Foundation, I think, and they actually use the term specifically to highlight the problem. And they actually think it's positive to use the term fatty liver. So I don't think you'll get agreement on everything, but I think it's key to remember that it is linked to the liver.
Okay, thank you very much. Professor Yu, would you like to ask questions regarding the second talk?
Okay, thank you. I have one question for Professor Kim. So, do you think in the future it is possible to put the MASLD and the FIFO score as the component of risk calculation for CV events? Because we know there are many risk calculators to predict the cardiovascular events like Bradman score, but according to your data, the patient with MASLD, especially those with advanced fibrosis, play a very important role in the long-term outcome of cardiovascular events. So, what do you think?
That's a very good question. Actually, I usually do not calculate the CVD risk in our outpatient clinic because we don't have much time during the outpatient clinic. So if there is any significant fibrosis and fatty liver, then I just consulted the cardiologist to check the heart and coronary arteries. So, you know, the AAC CVD risk calculator is only for the study.
Okay. So there another question from the audience. The Dr. Furuya asked that it is possible to control the progression of nephropathy and cardiovascular disease by altering the immune environment within the liver through personalization of a microbiome.
Yes, I think this is also a very good question. So although there are not enough data and I'm not the expert for the gut microbiome, but I think if the liver status is improved by the microbiome, the fibrosis regression may eventually occur. So I think that the long-term outcome will definitely improve in some patient.
I think one of the difficulties, I think one of the difficulties in this whole concept is there's so much redundancy in the system. So you fix the microbiome, but they're still eating hamburgers. You've got a problem. And they're keeping on putting on weight. So it just becomes when it's a lifestyle-related disease, it becomes very, very difficult to just perturb one, except you can do it in rats and show it, it's very easy. But in free-living humans, the redundancy is the problem.
Okay, nice comment.
The last question for you is that you show a very interesting data. If the patient have overweight, but without advanced fibrosis, without the metabolic abnormality, then
protective effect in the risk of cardiovascular events?
Yes,
What do you
maybe
think?
I think that the most important factor is the amount of muscle mass. There is some independent association between muscle mass and fibrosis, and muscle mass and the severity risk. So I think the muscle mass is the key point in the clinical aspect.
Okay, thank you. So since time is limit, I would like to handle the microphone to the Professor Tanaka for the question to the speakers. Okay.
Okay, so there is limited time. So, is there any questions? So, I'd like to move back to the secretary, or some discussion is there?
Maybe I'll ask Professor George
Yeah.
one question.
Yeah,
Now,
okay.
so you have talked about the many benefits of a GLP-1 receptor agonist. How about if the patient is having lean NAFLD? Do you feel comfortable in using this class of drugs?
I think the key is, I mean, we know now in the literature, in the diabetes literature, that you can get diabetes remission. And I guess it's to get the weight loss, but not, you don't want them to lose this. What you want them to do is get to a healthy ethnic specific weight. And your own study, Vincent, showed that in your lean patients, if they lost weight, they did better. The key is going to be able to define in that lean group how much weight loss. You don't want to do too much. And I think we know that all the GLP-1 agonists make you lose, they preferentially lose adipose tissue, but they also lose muscle. So it's very critical, particularly in your lean patients, that they must do some resistant exercise, because it's very hard to gain back muscle if you lose it, particularly because the average age of the patient is 50, 55, 60.
May I have some question for Professor George? That's how's the perspective? Do we need a new classification of pathophysiological assessment and cardiovascular risk score based on the hepatologist view? Thank you.
You mean having trying to get the liver? See, I think one of the problems is liver fibrosis, because it's just an endpoint of metabolic risk, is closer to your hypertension and your dyslipidemia and things. If you get liver fat, it's so early in the piece, you're just confounded by all these later events. But if we had a good fibrosis test, who knows? Maybe it can be included. Evidence-free zone.
Can I ask questions? So I just want to ask all the speaker and panels. I have two questions. I just wonder, is CLP and insulin level measured in all fatty liver patients to diagnose MASLD in your clinical practice? And if you have any MASLD patient, do you refer the patient to nephrologist, cardiologist, or endocrinologist?
Yeah, I answer first. In our clinical practice, the HSCRP and the insulin level are the mandatory the items we recruit into our patients check every half year, but that's for study, not for routine use. Before the 2 years ago, but after the new nomenclature of MAFO, we now start to recruit our patients with the new items. Thank you.
So there is, in China, they've actually set up about 130 MASLD clinics. And part of the workup before they come and see the doctor is blood pressure, albuminuria, just all those little metabolic factors, so that the doctor can actually just, we all are very, very busy. You can look up that cardiovascular milieu, and at least we should be able to know the targets. That's all I'm saying. I'm not suggesting that all of us have to become endocrinologists. by no means. I'm just saying that we need to know the targets, and we need to at least either refer to a cardiologist, or, for example, in a country like Australia, GPs do most of that metabolic management. But, they've got so many diseases to worry about. Someone like me saying, look, the blood pressure, he's only 5 years into hypertension. It is unacceptably high. The recommended target is this. The recommended target is this for lipid. That makes a difference.
Okay, maybe I can answer the second question. I think it's a very important question. So right now, the president of APASL, the Professor Lin here, lead a liver team and have a close talk with the Taiwan Association of the Cardiology and also the Taiwan Association of the Diabetes. And we try to have the position statement to set the criteria when we have to refer our patient to cardiovascular, cardiologist or endocrinologist, and also when the patient in their department have to consult the hepatologist. I think it's very important in the future for the so-called interdisciplinary teamwork for NAFLD, MASLD patients.
Okay, thank you.
Okay, I think we are almost run out of the time. So here I would like to close this APASL webinar episode. Here I would like to thank all the speakers and the moderator and also the president of Taiwan Association for Study Liver. And I think everybody learned a lot from the most updated comprehensive information, especially right now we have to think the patient with MASLD is not only a liver disease, but also a systemic disease in terms of the mechanism in the diagnosis and also in the management of our patients. So in the future, we have a lot of work to do, try to more specific understanding of the mechanism, the clinical cause, the long-term outcome, and also in cooperation with the cardiologist and endocrinologist. So thank you very much for all the audience and all the speakers and the moderators. Wish you have a good day. Thank you very much. Thank you very much.
Excellent.
Thank you. Thanks, everyone.
Very much.
Hi.
Thank you. Thank you, Professor Lin.
Thank you.
Thank
Bye-bye.
you.
Thank you.
Have a nice
Bye-bye.
day.
It's a great,
Bye-bye.
great
Nice
talk.
day.
Thank you.
Yo